equality.
Why advocates for same-sex marriage are also worried. That story this afternoon on All Things Considered from NPR News.
Tune to All Things Considered today from 4 to 7 on KGOU, your NPR source.
This is 1A. I'm Jen White. An estimated 40 million Americans traveled over the long holiday weekend with mask mandates on planes, buses, and trains no longer intact. But some of them likely weren't bothered because 1 in 3 Americans believe the pandemic is over. That's according to a Gallup poll released last week. The reality is COVID is still spreading across the country. The weekly new case average is roughly 94,000 cases a day. That's more than double what it was 2 months ago. Even as new cases go up, millions are still grappling with the lingering effects of their old cases. Last week, the CDC reported 1 in 5 Americans under 65 who've gotten sick with COVID have experienced at least one health condition related to long COVID. There are antiviral medications available to treat symptoms, but now some scientists are concerned about their long-term effectiveness. In the latest installment of our series, Vaccination Nation, we explore these challenges in more than 2 years into the pandemic. Joining us now is Dr. Rochelle Walensky, the director of the Centers for Disease Control and Prevention. Dr. Walensky, we appreciate you being here.
Good morning, Jen. Delighted to be with you.
So how concerned should we be about the rising number of COVID cases across the U.S. and their potential impact on our healthcare system?
You know, I think there are numerous things to consider here. One is we do have about 100,000 new cases a day right now, and we're watching this very carefully and working to educate the public as to what they can do to prevent more transmission spread. Important to also note that our hospitalizations are at about 3,500 a day, and our deaths are still at about 300 a day. So while those numbers remain higher than I'd like them to be, they're lower than they have been when we look at the ratio of what we've seen before with cases and hospitalizations and deaths. And that's because we have the tools now to conquer this with regard to both vaccination, boosting, and our antivirals. But I think it is important to note that the country is actually uneven in terms of where cases are distributed. We have about 55% of the U.S. population that is living in an area, location with either medium or high transmission. About 23% of people living in an area of high transmission. These include areas in the Northeast, in the upper Midwest, in the West, in the South, the Southeast. And so we really would encourage people who are in these areas of high COVID-19 community levels to continue to wear masks in public indoor settings to prevent transmission.
Well, in April, mask mandates on planes, trains, and in ride shares were lifted across the U.S. Have we seen an uptick in cases since those policy changes were implemented, or is it too soon to tell what effect they had?
You know, a lot of things happened at the same time, not just on our transport corridors were masks lifted, but they were also lifted in many local policies in regard to public indoor settings. So many things were happening at the same time. Things were opening up and policies were lifted. And I think much of that contributes to increased transmission. Of course, we have seen increased transmission occur after long weekends, after holidays, after breaks. And so we're watching that very carefully after this long holiday weekend. CDC does continue to still recommend that we continue to mask in our travel corridors, on buses and trains, our hubs, as well as in our airplanes, despite the fact that the federal judge has lifted the mandate.
We heard from a member of our text club on this issue, and they said, quote, the CDC should reinstate mask mandates on planes and trains and cruise ships. We're in Puerto Rico, and wherever we go out, almost everyone is wearing masks. If people can wear them in 90-degree weather, they can wear them everywhere in the States. What legal challenges does the CDC face at this point in trying to put mask mandates in place again on planes, trains, and cruise ships?
So this was overturned in a court, despite the fact that CDC has this recommendation. The CDC recommendations haven't changed. Just to be clear, at a local level, we have always encouraged local policy to be made at the local level. And so while we make our recommendations, all of those recommendations have to be implemented at the local level. At the federal level, with regard to transportation and across state transportation, we did have this mandate in place, and that was overturned in the courts. And so that is actively being adjudicated in the courts.
You know, many Americans are using at-home COVID tests, and the results of those often aren't reported to the government. So how accurate is our official data on COVID-19 spread at this point?
Yeah, that's a really important question, and we've been following this very carefully. It's important to also note that we are still doing about 900,000 PCR tests a day. So while we recognize that we are missing many positives associated with the rapid tests, we are being able to continue to follow trends because we're capturing about 900,000 PCRs a day. And this really does allow us to understand where cases are increasing, where hospitalization rates are increasing, and where we're seeing markers of severe disease.
Now, Pfizer's antiviral drug Paxlovid has become the leading treatment for those suffering from COVID-19 symptoms. More than 162,000 prescriptions were written for the drug just last week. How does Paxlovid work, and when is it most effective?
So Paxlovid is a really promising oral antiviral. The studies have demonstrated if given in people who are unvaccinated, who are at risk of severe disease, it prevents about 88% of their hospitalizations. But you need to use it early. So we are encouraging people to have symptoms to get tested early, and then now to get that Paxlovid prescription within 5 days of your symptoms so that you have the best chance, if you're at risk of severe disease, of having it work best.
Now, why is the CDC warned of a COVID-19 rebound after patients take this drug? Exactly what's going on?
Yeah, really important. So this we have started to see in a minority of cases, although more and more being reported, that people may, after their 5-day course of Paxlovid, have a resurgence, recrudescence of their symptoms. And so those symptoms might return in this minority of patients, and they may actually have a viral rebound as well, which is why we do want patients and providers to be on the lookout for this and to know that this might happen. Importantly, though, we also want to emphasize that we haven't seen people get sick after they have return of their symptoms. And so we still think that this is a really important tool in our toolbox. It's keeping people out of the hospital, and we don't want people to be reluctant to use it because they might be worried that their symptoms might return.
If patients experience that rebound, how are doctors responding? Is it another dose of Paxlovid?
So we're not actually recommending another course of Paxlovid at this time. What we are recommending is that you put your mask back on and maybe you isolate for another 5 days, just in case you might be symptomatic and be able to spread the disease to someone else.
Now, the CDC found 1 in 5 COVID survivors under 65 in the U.S. have experienced a health condition that could be considered a long COVID symptom. How well does the CDC understand long COVID, and what questions do you still need to answer?
Yeah, this was a really important study on over 350,000 patients who had COVID and compared to over 1 million patients who hadn't had COVID. And we looked at not just those symptoms that we classically think about with long COVID, the brain fog, fatigue, neurologic symptoms, but a whole host of what we're calling post-COVID conditions. That could be anything from new onset diabetes to blood clots to new onset renal insufficiency, kidney insufficiency. And so we have seen, as you note, 1 in 5 adults had one of these post-COVID conditions, some of which associated with long COVID, these other post-COVID conditions. There are still many questions that we have to answer, and studies are ongoing. So questions like, are you protected if you've been vaccinated or if you've been boosted? Does it matter which variant you had? Does it matter if you've been previously infected with COVID before? So all of those studies are continuing to be underway.
I mentioned that Gallup poll earlier. 1 in 3 Americans believe the pandemic is over. A fifth consider their lives to be completely back to normal. But we heard from many in our text club who think the CDC needs to do a better job with messaging. Here's some of what we heard. Do a better, more consistent job by messaging people in different ways according to their age and language. We still must be diligent in avoiding COVID. Another person texted in, the CDC needs to keep pushing the message that COVID is still among us. Get the heads of government to continue to push for vaccines, boosters, and using common sense. What is the messaging strategy for the CDC at this stage of the pandemic?
Well, part of that message is why I'm here with you today, to let people know that we still have 100,000 cases a day. We are still working to prevent certainly severe disease and deaths from this pandemic. And really to reach out. This past week, we expanded our booster recommendations for boosters above those above the age of 5, as well as for fourth shots among all those above the age of 50. So we continue to lean in and to recommend masking in areas of high transmission, to recommend and high COVID-19 community levels, to recommend vaccination, recommend boosting, and really to do a whole lot of outreach in many, many different communities with trusted messengers.
In May, we passed a milestone that was once inconceivable. More than 1 million American lives lost to the coronavirus pandemic. And the reality that roughly 300 Americans a day are still dying of COVID. Are there tools you want access to right now that you don't have access to continue battling this pandemic?
This was a tragic milestone, one we never anticipated would be occurring through this pandemic when it first started 2.5 years ago. I still think 300 lives lost every single day is far too many. We do have so many of the tools that we need when we think about the vaccines and the boosters that we have to keep people out of the hospital to prevent death. When we look at the Paxlovid and the antivirals that we have, we still have our masks that we can use to prevent infection. And really the work that we have now is to get the outreach that's necessary to communities, to people, in order to uptake these prevention mechanisms. I will say we have, about 30% of our children between the ages of 5 to 11 who've been vaccinated, about 60% of our teens between the ages of 12 to 17. Still a lot of boosting that needs to be done over this last increase in cases. More of the deaths have been occurring in people who haven't been boosted or elderly. So all of those messages continue to need to be sent.
That's Dr. Rochelle Walensky, Director of the Centers for Disease Control and Prevention. Dr. Walensky, we appreciate your time.
Thanks for having me.
Coming up, millions of Americans continue to suffer long-haul COVID symptoms. We'll hear your stories in a moment. I'm Jen White. This is 1A from WAMU and NPR.
This is the Manager's Minute. A couple of changes are coming to the KGOU program schedule June 6th. We're adding another segment of Asian View each weekday morning, so it will now air at 5:01 and 5:42 a.m. Asian View features news and analysis from Japan and the rest of Asia. We're also adding a new daily feature, Soundbeat, weeknights at 9:58. Soundbeat is a 90-second segment that focuses on the history of recorded sound. Soundbeat tells the stories of distinctly American forms of music, popular and classical, jazz, bebop, country, opera, film scores, and more. Plus, you'll also hear about speeches and spoken word performances from historical figures in the 19th and 20th centuries. Asian View and Soundbeat will replace Pulse of the Planet, which concludes its more than 30-year run this week. With the Manager's Minute, I'm Dick Pryor.
Our forecast calls for off and on showers and thunderstorms throughout the day. Some storms could produce heavy rainfall. Look for afternoon highs around 65 degrees in northwestern Oklahoma to low and middle 70s around the metro. More rain chances this evening and throughout the overnight hours, lows in the mid-50s to low 60s. This is KGOU, your NPR source.
Support for NPR comes from this station and from C3AI. C3AI software enables organizations to use artificial intelligence at enterprise scale, solving previously unsolvable problems. C3AI is enterprise AI. And from Aspiration, a digital banking alternative designed for people who care about the environment. Customers can plant a tree with every swipe of their debit card to offset their carbon footprint. Aspiration.com/green.
I'm Jen White. This is 1A.
My name is Lindsay, and I live in New York.
My name is Meredith, and I have a son who's 16.
he actually did have long-haul COVID. He has it now.
I was diagnosed with COVID-19 and subsequently long COVID back in early April of 2020. My long COVID symptoms became very severe about 3 months later.
He has brain fog, lack of concentration, difficulty sleeping. The neurologist told us these symptoms could last for 6 months, and they don't know when it will wane.
I really struggled with my breathing and my activity level, and I still suffer from chronic fatigue syndrome.
A new report from the CDC recently found that millions of Americans, 1 in 5 who've gotten sick with COVID-19, have at least one health condition that could be considered long COVID. It's 1 in 4 for those over the age of 65. How much do we know about long-haul COVID cases more than 2 years into this pandemic, and what treatments are available? Joining us now is Dr. Ziad Al-Ali, the director of the Clinical Epidemiology Center. He's also the chief of Research and Education Service at Veteran Affairs St. Louis Healthcare System. Dr. Ali, we appreciate your time.
Well, thank you for having me.
Also with us is Dr. Angela Rasmussen, a virologist at the University of Saskatchewan. Angie, it's great to have you with us.
It's great to be here, Jen. Thanks.
And if you or a loved one continues to struggle with long-haul COVID symptoms, we'd love to hear your story. Tweet us at 1A or send us an email at 1A@WAMU.org. Dr. Al-Ali, you've been studying the effects of long COVID for more than a year. Were you surprised to learn that so many Americans are experiencing these symptoms?
It is still jarring. Every time we look at the data, it's absolutely still jarring. Sort of the not only the scale of it, but also the breadth of organ manifestations or organ system dysfunction that we see in long COVID. People generally associated with fatigue and brain fog, but it's absolutely much more than that. We see neurologic manifestations. We see metabolic manifestations in the form of new onset diabetes, heart problems, arrhythmias, kidney problems. So it's really not only the scale of it, but the breadth of organ dysfunction that we see in long COVID is absolutely jarring.
And do the numbers that were reported by the CDC reflect what you're seeing at your veterans clinic daily?
Well, these are sort of consistent with our evolving understanding of, the scale of it, how common it is in the U.S. population, and also the range of clinical symptoms and clinical manifestations that we see in people with long COVID.
Angie, SARS-CoV-2 has been around for a little more than 2 years at this point. How much focus has long-haul COVID gotten among public health experts?
Well, it's getting increasingly more focused, and certainly it is a topic that I and many of my colleagues have been talking about since 2020, but at the same time, it hasn't gotten enough attention, I don't think. And part of the reason for this is, as we were just discussing, there are many different manifestations of it, and I think people have a really difficult time coming to grips with the fact that it is so common and that it has the potential to impact millions and millions of people. I think that people are starting to appreciate that, but there's no question that we should have been paying more attention to this a little bit earlier. We also should be really hard at work trying to figure out what the causes are and what the treatments might potentially be, because this is really, really impacting a lot of people's lives.
Dr. Al-Ali, we have seen people have such different responses to COVID itself. Symptoms, vary, severity varies. Why is each person's individual experience with the virus so different?
It's unclear at this point, but what's absolutely clear is that some people are totally asymptomatic, meaning that they don't even know they have the disease when they got COVID-19. And then some people have severe disease to start with. But regardless, we actually see people with long COVID who had asymptomatic disease, all the way to people who really been in ICU during the acute phase, later on also manifesting with long COVID. So literally long COVID can affect everyone, even those people whose disease was very mild or asymptomatic to start with. Weeks down the road or months down the road, they come back to clinic with brain fog, fatigue, and other manifestations of long COVID.
I want to bring another voice into the conversation. Joining us now is Rebecca Hike, an assistant professor of epidemiology at Augustana College in Illinois. She's had long-haul COVID symptoms since September 2020. Rebecca, thanks for being here and sharing your story.
Thank you so much for having me.
So you first contracted COVID when did you contract it exactly?
September of 2020.
And it's now June of 2022.
Yep.
What symptoms are you continuing to experience more than a year and a half after your initial diagnosis?
Well, as you can hear, my voice is incredibly hoarse today. This has been an ongoing challenge for me. I have a lot of respiratory issues, and I also have a lot of neurological problems. I have a lot of brain fog. Pardon me. So I think, probably for me, the respiratory and the neurological pieces are the biggest ones. But I don't have a body system that hasn't been affected. I continue to struggle with a skin rash that we can't seem to get cleared up. Digestive issues. My taste and smell continue to be altered. So lots of different struggles. But yeah, at this point, I had really hoped that things would be improving.
Sort of lay out the timeline for your illness. You contracted COVID. Was there a period of recovery for you before the long COVID symptoms started to emerge?
For me, not really. So I contracted it in mid-September of 2020, and it was late November, early December before I really started feeling better. But a lot of my symptoms never went away. So the respiratory issues never cleared up. The changes in my asthma continued to kind of worsen over time. And the neurological problems, I don't know that I noticed them as much when I was sick. But as I kind of got to the place where I was getting back to some semblance of normalcy, I noticed almost right away that I was having a lot of brain fog type issues. My memory wasn't very good. I had a hard time with word retrieval. And there would be times when someone would say something, and if I wasn't completely focused just on them, if there was background noise or anything, I would have to have them repeat it. It was almost like I just couldn't sort out what I needed to be listening to. And those issues never really stopped.
In talking to doctors, are they able to explain why your body is reacting in this way? Do you have clarity about that?
The doctors I've worked with have offered a couple of possible explanations. One is that there is, an autoimmune component to what's happening. And that's what's upset the system. And the other is, of course, that potentially there's virus in the system that my body is continuing to respond to, because I have a lot of inflammatory issues as well. But none of the specialists that I've worked with thus far have really been able to say for sure what's causing my long COVID and exactly how we might address that as a whole. It's more about trying to address the individual symptoms or system issues that I'm having.
We got this email from David who asks, do those with long-haul COVID still have the virus in their system? Are they still potentially contagious to those around them? Dr. Alali, what do we know?
So no, it's unlikely that they actually still have the virus in their system in a way that would be contagious to other people. Now, there are theories there to sort of really suggest that maybe the pathogenesis or the reason some people are having long COVID is persistence of the virus in immune privileged sites. There's sort of really sites in the body where the immune system cannot access. But those people are unlikely to be contagious. So people with long COVID are absolutely not contagious beyond the acute phase of the disease. We definitely don't want to stigmatize them any further than they already are. And it's a very, very important point to make. But one of the hypotheses, one of those sort of the mechanisms or the explanations of why long COVID happened in some people is that the body is not able to fully clear the virus. There are fragments of it or small pieces of it that reside in what they call immune privileged sites.
We know fully vaccinated individuals have higher protection from getting acute COVID symptoms, but what level of protection do vaccines provide against long-haul COVID? Do we know that, Angie?
So we don't really know that. There have been some studies that have looked at this, and some of them do suggest that people who have been vaccinated are less likely to develop long COVID symptoms should they have a breakthrough infection. But unfortunately, many of these studies don't completely agree with each other. There are also some studies that suggest that vaccines don't really offer significant protection against long COVID for people who have breakthroughs. And as Dr. Al-Ali pointed out, there are a number of people who have asymptomatic infections or very mild acute symptoms that then do end up developing fairly severe long COVID symptoms. So really, this is a very important, I think, open question, because without fail, the vaccines do essentially reprogram your immune system to provide you better protection against acute COVID. It makes sense to hypothesize that they would also reprogram your immune system to be less likely to produce some of these dysfunctional immunopathological conditions that Rebecca was describing, for example. But again, this is something that is very much a black box and a big question mark, and something that I think we really do need to get to the bottom of.
Dr. Al-Ali, you've done some research in this space. What have you found?
So in our research, we found that vaccines do offer some protection, but not complete protection from long COVID. Overall, the degree of protection was modest. We put around 15%. That's 15% reduction of risk of long COVID. So that's nothing. That's not zero risk reduction, but it's really not on its own and solely sufficient to protect people from the risk of long COVID.
We're talking to Dr. Ziad Al-Ali, epidemiologist and chief of research at the St. Louis Veteran Affairs Healthcare System, Angie Rasmussen, a virologist at the University of Saskatchewan, and Rebecca Hike, an assistant professor of epidemiology at Augustana College. She continues to live with long COVID symptoms. I'm Jen White. You're listening to 1A. We're also hearing from you. Tim emailed us, my family, myself, and my roommates are experiencing intense tinnitus from long COVID. It makes it impossible to sleep and has been going on for almost 2 years. It's deafening. We also heard from Angela in Fayetteville, North Carolina, with this story.
It's been a challenge getting the medical and community support and understanding that I need. This disease is not always visible. My body is not disfigured in any way. To look at me, I look much the same as I did before COVID. However, I am drastically different. The medical providers that I've encountered are not prepared for the barrage of symptoms and the effect that this disease has. It can look quite different from patient to patient. Some providers have a very limited understanding. That's why I feel it's important to be your own advocate and learn as much as you can to help guide and manage your care. Listen to what your body is telling you, even if your doctors, nurses, or others doubt your symptoms.
Angela, thanks for sharing your story. Photopotamus also tweeted, I was a very active person before getting COVID in October of 2020, but my ability to do daily activities, work, and care for my kids has been drastically limited. I'm still struggling to get some kind of diagnosis. Several doctors have blamed my weight. You can tweet your story at 1A or send us an email at 1a@wamu.org. Dr. Al-Ali, Alyssa emailed us asking, how is long COVID diagnosed?
So currently there is no really standard biomarker or standard test by which we diagnose long COVID. It's really reliant on the patient reporting their symptomatology in the post-acute phase of the disease. That's really after the first 30 days. In some instances also after the first 90 days of the disease. They often come with symptoms like fatigue or brain fog or new clinical problems in the form of new diabetes or kidney disease. Again, I think that the whole disease or the whole long COVID is really new, and we're still trying to understand it and develop biomarkers to really definitively test it in the clinic. There are a lot of studies being going now actually underway to develop those biomarkers and those tests to be able to identify and diagnose long COVID with more accuracy and precision.
Rebecca, what has your experience been when it comes to seeking medical treatment for long COVID?
I've been really fortunate. My primary care provider was very in tune with what was happening with me. Believed what I was telling her, and was able to refer me to Northwestern's chronic COVID clinic in Chicago, Illinois. And my experience has been with the vast majority of those providers that they listen, that they are responsive, that they believe that long COVID actually exists. I did, however, encounter one provider who I think honestly questions if long COVID is real. And made very light of the symptoms that I'm experiencing. That provider in particular was supposed to be assessing issues I was experiencing with severe joint pain, inability to use my hands because of pain, etc. And to be really honest, if he could have kind of patted me on the head and told me that it would all be fine and sent me on my way, that's probably exactly what he would have done, which is really frustrating. But the flip side of that is I've been very fortunate that all of the other providers that I've worked with have been very just really supportive and encouraging that we're going to continue to look for answers and solutions to the problems that I'm experiencing as well as so many others are experiencing.
Rebecca, you're going through this experience as an epidemiologist studying COVID. How have you advocated on your behalf when you face that kind of skepticism?
One of the things that I did actually as soon as I was diagnosed was to step forward on the Facebook page that I have for epidemiology and begin sharing my story. And I've continued to do that throughout my long COVID journey as well. And I think that one of the big things for me as an epidemiologist is to ensure that when I talk with people about, not medical providers really, but with other people about it and about what I'm experiencing, I also talk with them about the science in a way that they can understand. And so helping them understand that the only way for us to really prevent long COVID is to prevent COVID is, I think, a really key piece of it. But I also think it's important that people understand that these studies of long COVID are just kind of getting started. And as an epidemiologist, obviously, to me, those early studies, they're so important, but they're only the very beginning of what we will know about long COVID. And honestly, my hope is that perhaps with more learned about long COVID, maybe it will open some doors to learning more about other chronic illnesses that are, similar to it in some way, chronic fatigue syndrome, et cetera.
We're talking to Rebecca Hike, an assistant professor of epidemiology at Augustana College, Angie Rasmussen, a virologist at the University of Saskatchewan, and Dr. Ziad Al-Ali, an epidemiologist at the St. Louis VA. Back with more in a moment. This is 1A. America's farmers are under pressure to produce more, but roughly 1/3 of their total harvest is never consumed since many products naturally have a short shelf life. CRISPR, a gene editing technology, is changing that, but at what risk to biodiversity? Our agriculture series, Deeply Rooted, continues next hour on 1A.
I'm Maggie Schoenfeld with information about upcoming events from KGOU's online community calendar. The Dead Center Film Festival takes place June 9th through 12th, featuring over 1,400 independent movies by filmmakers across the globe in a wide selection of genres. The festival includes panel discussions, screenwriting competitions, and screenings in various locations around downtown Oklahoma City. The Summer Breeze concert series continues Sunday, June 12th, with Heather May and Chris Matthews performing together at Lions Park in Norman at 7:30 p.m. Heather May is influenced by bluegrass and jazz, while Chris Matthews' music is an eclectic fusion of genres. For more information about these events and others, visit our website at kgou.org.
Support for NPR comes from this station and from Angie, formerly Angie's List, dedicated to helping homeowners tackle home projects from everyday repairs to dream remodels. Reviews, pricing, and booking are at Angie.com or on the Angie app. From Hint, maker of fruit-infused water with no calories or sweeteners. Available in more than 25 flavors, including watermelon and pineapple. In stores or delivered from drinkhint.com. and from the listeners who support this NPR station.
Back to our conversation in a moment, but first we'd love your help with the show we're putting together for next week. Mass shootings have happened in other countries, though nowhere near as often as they do in the U.S. What questions do you have about how other countries have responded to mass shootings? Leave us a voicemail, 855-236-1A1A. Are you from a country, perhaps Australia, New Zealand, Canada, or the U.K., that tightened restrictions after a tragedy? How are you reflecting on this moment in the U.S.? Tell us your story, 855-236-1212. You can also send us an audio file with our app, 1A Vox Pop, and we'll share some of your stories Tuesday on 1A. Now let's get back to our conversation about long-haul COVID. Angie Rasmussen is with us. She's a virologist at the University of Saskatchewan. Also with us, Rebecca Hike, an assistant professor of epidemiology at Augustana College, who has long COVID, and Ziad Al-Ali, an epidemiologist at the St. Louis VA. We're also hearing from you. Dr. Melissa Heineman called in from Illinois. She's a clinical psychologist.
I've been treating clients who have been experiencing ongoing long COVID and associated depression and anxiety. There is a really significant amount of people who are struggling with neuropsychiatric impacts related to long COVID. Hopefully the research catches up sooner than later about what will be more helpful for these folks. But I would encourage everybody who's struggling with long COVID, it is very reasonable and helpful to reach out for mental health services.
Dr. Heineman, thank you for that. Do you or someone you know continue to struggle with long-haul COVID? Tweet us at 1A or send us an email at 1A@WAMU.org. We also got this message from Broham, who tweeted, "Most people are tired of talking about it and just want to move on. It's affected many of our lives so greatly. I have struggled every step of the way. I've been on disability since November 2020. My insurance and disability companies have not wanted to cover various tests and or procedures." Now, Angie, long COVID can qualify for a disability under the ADA, but it isn't guaranteed because the HHS requires a quote, individualized assessment of each case. What challenges could this raise for people who are trying to make the case that they have long COVID?
Well, I think one of the big issues here is the fact that long COVID is really, really diverse. So it presents in different people in different ways. And I'd be very curious also to hear Dr. Al-Ali's perspective on this, since he's actually treating many of these patients. But I think that makes it very difficult to have a standardized way of assessing whether somebody has long COVID or not. And as Rebecca has pointed out, there are providers out there who don't actually believe that long COVID is a condition that is really disabling to some people and that is really harming and impacting their lives. And so if a patient sees a provider who doesn't take their symptoms seriously, who doesn't think that they're actually suffering from a legitimate medical condition, that makes it very difficult to have that individualized assessment that's going to say that this person does have a disability that's protected under the ADA and this person needs to be accommodated.
Dr. Al-Ali, I'd love to hear from you on this as well.
Sure. I really think that the biggest challenge that facing people with long COVID these days is really a healthcare workforce is really untrained, is not really prepared to deal with patients with long COVID. Nobody went to medical school learning about long COVID. It's all a new disease, and it's really incumbent upon us and professional societies and all relevant stakeholders to educate and train the community of providers so they actually recognize the illness, validate the patient experiences, are more prepared to embrace it and treat it. We cannot really move forward without really having the medical community, medical providers or healthcare providers throughout the country having some sort of training or some sort of at least a basic training of what long COVID is. They're going to encounter it in the in the general practitioner clinics and the psychologist clinics. It's going to be everywhere, and it's very important that our medical workforce is really prepared to address the needs of those patients.
We also got this email from Ken, who says, "I have a friend who's had long COVID symptoms for 2 years. She contracted COVID in early 2020 before we had testing, so she never got a positive test. As a result, she doesn't have a diagnosis and therefore doesn't qualify for long-haul clinics or research studies, etc. Can any of your guests offer her help?" Dr. Al-Ali, any advice here?
So this is absolutely the case, and there are a lot of people, especially early in the pandemic, when testing capacity was constrained. Testing was not administered unless you really, really were sick or even in the hospital. So a lot of people actually had COVID, but they don't really have a test to prove that they actually had COVID. Some of those patients, unfortunately, went on to develop long COVID. Not having a test, a positive test in March 2020 or April 2020 to document positivity for COVID does not mean that these patients don't have long COVID. We need to, acknowledge their real experiences, what they're complaining about with their symptoms and their manifestations, and treat them as such. It's really our failure as a medical system of not having ramped up testing capacity sufficiently enough to be able to cover all people who actually got COVID in March 2020 and April 2020 and May 2020. Remember, that time period, testing was severely constrained. If you walk into a clinic, you couldn't get tested unless you're really, 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 really very sick.
So is there any advice for someone who's in that situation? Is it about finding the right provider who can provide the support you need?
So long COVID clinics or post-COVID clinics throughout the country will know this reality and will treat that patient as a long COVID patient. And that's really what my point was, to try to educate the community of providers that some people, especially early in the pandemic, actually had COVID, but don't have documentation to prove, or a test to prove that they had COVID test and COVID. Especially if these people went on to be vaccinated, it's very hard to sort of determine, if they actually had if they had COVID. But if they are showing symptoms that are, indicative of long COVID, they should be treated as such.
Rebecca, what treatments are you taking to address your long COVID symptoms, both mental and physical?
So currently, I am being treated for anxiety and PTSD, as well as an executive function disorder. So from a kind of a psychology, neurological standpoint, and I'm doing medications for the anxiety, and I'm also in therapy at this time. I'm also receiving speech therapy to try to work on the hoarseness that I have, in addition to occupational therapies to help with some of the cognitive problems I'm having. And actually, at present, I'm also in physical therapy. So I'm also using medications to, like gabapentin, for example, to help control the nerve issues that I'm having. I have a lot of nerve pain. It also helps with the ongoing muscle cramping that I have. And so at this point, it's basically just symptomatic treatment as we identify things. We also altered all of my asthma medications to try to get that more stable as well since I've had COVID.
Dr. Alali, as we're hearing from Rebecca, there are some medications or treatments available to address some of these symptoms, but why haven't there been medical treatments developed specifically for long COVID patients?
This is an absolutely very important point. And this is really a major gap in our portfolio. We definitely need to take long COVID more seriously and devote resources to it to really be able to discover new treatments for it. If you ask me now, what are the FDA-approved treatment modalities for long COVID? Zero. None. There's no new medication that has been approved over the past 2 years or 2.5 years to treat long COVID specifically. And that's really a major glaring deficiency in our sort of tools to combat and treat and address the pain and suffering of people with long COVID. Currently, primarily, most of the treatment modalities, as outlined by Rebecca, are really symptomatic, and that's really not enough. We definitely, there's an urgent need. Again, I cannot really stress this moment enough. There's an urgent need to test as many therapeutics as possible in people with long COVID and discover what works and what doesn't, so we can learn and iterate from there, so we can really offer real help to these patients.
And do you feel like there is movement in that direction?
Absolutely. There is movement. In my world, there's not enough, so I sort of like feel that really this really demands an orchestrated response from not only the federal government, but also private sector, all the companies, all drug companies to rally together and work together with the same urgency and intensity that we've done to develop antivirals and to develop vaccines. We've done a remarkable job developing vaccines in record time. Long COVID is our next challenge. Is really the challenge of the moment. now. The question is, can we meet it? And really, it has to be the concerted effort of all stakeholders, not only the U.S. government, but also the private sector, to really coalesce around each other and then really develop a strategy to get treatment as soon as possible. It needs to be treated with the same urgency and the same intensity that we treated COVID-19 in the first place and developed a vaccine in record time.
Let's go back to our voicemail box. We got this message from one of you who believes studying a different illness could help provide some answers about long-haul COVID.
Hi, this is Chris from Chicago. Long COVID is myalgic encephalomyelitis, what we used to call yuppie flu back in the 80s. Current researchers would be very interested in looking over all this. They would create better research. We're very close to finding treatments and answers to this complex medical mystery.
Chris, thanks for that message. We're talking to Dr. Ziad Al-Ali, an epidemiologist at the St. Louis VA, Angie Rasmussen, a virologist at the University of Saskatchewan. Rebecca Hike is also with us. She's an assistant professor of epidemiology at Augustana College. She also has long COVID. I'm Jen White. You're listening to 1A. Angie, what can you tell us about chronic fatigue syndrome and its similarities to long-haul COVID?
Yeah, so there are many similarities between ME/CFS, as the caller was just describing, and long COVID. Some of the similarities include similar symptoms, so the brain fog, the neurological conditions that we've been discussing. And they're also fairly diverse diseases. So not every single ME/CFS patient is experiencing the same symptoms, just like not every long COVID patient is experiencing the same symptoms. And like long COVID also, ME/CFS has really been essentially neglected by much of the biomedical research community. There haven't been enough funds to really dig into it and try to understand mechanisms. It may be that long COVID and ME/CFS are really a spectrum of different diseases that manifest differently in different people. So I do agree with Chris, the caller, that looking more into ME/CFS would probably give us insight into long COVID. And I should add, too, that long COVID is not the only post-acute viral infection syndrome that's out there. After the 1918 pandemic, there was an epidemic of something that was called, at the time, lethargic encephalitis that has been described as sounding an awful lot like long COVID. More recently, in survivors of the Ebola virus epidemic in West Africa and in the Democratic Republic of Congo, there are a number of Ebola survivors also who report these similar symptoms, so brain fog, neurological conditions. And that, too, sounds an awful lot like some of the symptoms described by long COVID patients. So I would suggest that in general, we really do need to be paying a lot more attention and try to understand the mechanisms of these long-term post-acute viral infection syndromes.
We got this question from Zachary, who tweeted, is dehydration also associated with long COVID? My partner is having all the same issues since January, and we think she contracted COVID in December. No doctor seems to know what is going on with her. Dr. Al-Ali, is this a symptom you've seen?
So I'm not really sure exactly what they're referring to when they say dehydration. So some people with long COVID experience palpitation of the heart and also changes in blood pressure when they stand up, and that's sort of now is really well recognized. Generally people, so as a general rule of thumb, people should remain hydrated, and if they drink plenty of fluids and make sure that they're continue to be hydrated.
Rebecca, how has your experience with long-haul COVID changed your approach to teaching public health?
I think that it's really reinforced the need to put a face on the things that we study. It's easy to get kind of tangled up in the numbers and in these really big pictures of things. But I think that especially when you're working with students who are just learning about public health, it makes those things a little bit faceless. And I think it's easier to kind of brush off some of the things we talk about if those problems don't have a face and a story to go with them. And, and the thing is, it's not just my story, it's the story of millions of people who are experiencing this, but that reinforces the importance of what they're learning.
What public health changes would you like to see to better support long COVID patients?
I think, obviously, as everyone has mentioned today, additional epidemiologic studies, not just in clinical settings, but in population settings. So looking at large numbers of people and getting a good assessment of how frequent these types of symptoms are, how long they've been ongoing, and allowing those studies then to go forward into the future to see what the process looks like with long COVID for people. I also believe that one of the big things, as I mentioned earlier, about preventing long COVID is preventing infection. And I would really like to see public health as a whole continue to work on how we message around infectious disease prevention, and also how we message around things like vaccination, for example, and reminding people that these public health actions that we're asking them to take are actually about much more than just protecting themselves as an individual. It's actually about protecting all of those who are around them. Loved ones or strangers alike can be protected by public health actions. And I think we really need to work on greater interaction with the public to help them understand that.
Angie, really briefly, in just a sentence or two, how do you think we should think about this current stage of the pandemic, considering the number of reinfections we've seen?
Well, I think we need to first and foremost think that the pandemic is not over. As Dr. Walensky said earlier, there are 100,000 new cases a day. That is not an endemic or low level of transmission. We really do need to continue thinking about this as a real threat that we need to avoid getting, if at all possible.
That's Angie Rasmussen. She's a virologist at the University of Saskatchewan. Also with us, Rebecca Hike, an assistant professor of epidemiology at Augustana College. Rebecca has long COVID. And Dr. Ziad Al-Ali, an epidemiologist and chief of research at the St. Louis Veteran Affairs Healthcare System. Thanks to you all.